Welcome to Disaster Preparedness and Risk Management, which is part of the Program on Occupational Health and Safety Education on Emerging Technologies Mid-Atlantic Partnership, also known as PocketMap. Today we're going to talk about basic concepts that are essential for public health practitioners and other stakeholders to know regarding public health emergencies and disasters. This is intended to be highly applied and applicable to current and emerging threats. Let's begin with the concept of emergencies and disasters. And I want to list on this slide some key examples of events that we're seeing an increasing frequency and severity of. These include natural events such as earthquakes, hurricanes, floods, and tsunamis, technological or human-made error such as hazardous material spills or explosions, intentional acts such as terrorism events through various modalities, epidemics, as we are seeing right now with COVID-19 at the time of this recording, and future threats of a pandemic nature that will likely emerge. And last but not least, conflicts and war. These all constitute what we consider to be emergencies and disasters. But I want to build upon that set of comments through a definitional distinction here. An emergency, by definition, is an event that can be handled by local resources alone. A disaster, in contrast, is an event that requires outside assistance. The term emergency and disaster, therefore, is a relative concept based on the baseline resources and availability of a jurisdiction to respond. An event that could be handled locally in one jurisdiction, which would therefore be called an emergency, might be a disaster in another jurisdiction which does not have the same baseline resources to respond. In any event, these terms are often used interchangeably, and we'll present them that way in this presentation. So here are some more detailed definitions of emergencies versus disasters. This comes from Webster's. An emergency here is an unforeseen combination of circumstances or the resulting state that calls for an immediate action. A pressing need, in other words. A disaster is a sudden calamitous event that can bring great damage, loss, or destruction. But again, as I had mentioned a moment ago, an emergency by definition is an event that can be handled by local resources alone, while a disaster is an event that requires outside assistance to aid that jurisdiction that's affected. Let's talk about some other key definitions as we introduce the concepts here. So one of the key terms that is important to know is the term hazard, and that has been defined as a source of danger that may or may not lead to an emergency or disaster. Risk is another key term, and that means susceptibility to death, injury, destruction, disruption, or stoppage. And as I alluded to earlier, but am amplifying on here, disaster in this context is defined as an event that demands substantial crisis response requiring the use of governmental powers and resources beyond the scope of one line, agency, or service. In other words, that requires outside resources. Let's talk about some unique problems and challenges related to disasters. And these kinds of challenges that I'm going to mention on this slide occur again and again. And it's important to think about in current and future events. So one of the unique challenges in disasters is warning and evacuation. How to warn the public about an impending event or new threats within an ongoing event, such as COVID-19, such as new variants that are emerging at the time of this recording. Evacuation, how and when and whether to evacuate. Another unique problem in disasters is what we call triage. Triage is French for sort. So triaging and victim and casualty distribution. There's something called reverse triage in disasters, where in contrast to how medical care is delivered on a day-to-day non-disaster basis, in a disaster, often it's the case that those with the greatest likelihood of survival who are affected by an event get seen first in order to manage limited resources for response, as difficult as that may be. Urban search, rescue, and recovery are extremely challenging elements. Large-scale victim and responder mental health issues, and please note that I mentioned responder mental health issues. We also, in addition to addressing the mental health needs of those who are affected by an event, we have to think about first responders as among those individuals who are susceptible to mental health adverse outcomes. We call that caring for the caregiver. And last in this list is coordination among multiple agencies, jurisdictions, levels of government, and the private sector. It really takes a multi-sectoral approach to yield an effective response to a disaster, and that can be challenging. On this slide is depicted something called the disaster life cycle, and I'll begin at 12 o'clock on the dial for this diagram. The disaster life cycle comprises 4 phases. Ideally, at the top of this diagram, we want to prevent a disaster from occurring in the first place. For example, if a construction site contains hazardous materials that, if gotten into the wrong hands, could be used for an intentional act, we want to secure that site. That's an example of prevention. The next phase is preparedness. Preparedness, interestingly, is often used as a general term to refer to this whole life cycle, but it has a very specific meaning here, and I want to emphasize that. Preparedness, and that's at the 3 o'clock part of the dial, refers to a mini continuous quality improvement cycle before an event occurs that comprises planning for the event, doing drills and exercises in advance of the event, training in advance of the event, and then assessing what was learned from those trainings and exercises to be optimally ready for the next phase, which is at the bottom of the dial, response. Response to disasters often gets the most media attention. It is quite dramatic, understandably so. Response can occur from within seconds to hours to days to even weeks following the onset of an event. And this, again, is what receives typically the most media attention in the wake of a disaster. The last phase, and I say last but not least here, is recovery phase. Recovery following public health emergencies and disasters is a long-term process. For example, at the time of this recording in 2022, there are parts of hurricane-affected jurisdictions from several years ago that are still in the recovery phase following those events. Recovery doesn't just mean physical infrastructural recovery, it also means mental health and psychosocial recovery. So long after the media has stopped covering the acute response, a critical role for public health and other stakeholder agencies is to facilitate recovery. And those kinds of recovery activities include mental health care for the caregivers, long-term mental health surveillance for affected communities and provision of care. Registries, for example, such as cancer registries or other long-term health adverse outcome registries, has been seen in the wake of the September 11, 2001 attacks in the United States to monitor the health of responders to the ground zero site. So all of these phases of the disaster life cycle are critical, and it's important for all public health practitioners and other stakeholders to be mindful of these phases and why they're important, as I just alluded to. On this slide, I've depicted what's called the Public Health Emergency Preparedness System, sometimes referred to here as the Public Health Preparedness System. This has been developed by the Institute of Medicine, now NASCM, and has been iterated upon. And the basic premise of this diagram is that the hub of response to public health emergencies is, as depicted in green at the center of this slide, the governmental public health infrastructure. And by that I mean public health agencies. There's a maxim in disaster readiness and response that says that all disasters begin locally. Even if disasters, as I mentioned earlier, require outside assistance from other jurisdictions to facilitate response, the lead agency in disaster should be the local governmental agency. And in an infectious disease emergency, such as a pandemic or a disaster that involves public health, the lead agency at the hub of this diagram would be the local health department. Going from 2 o'clock clockwise around the dial for this diagram, other interlocking and interacting partners for this public health preparedness system include Homeland Security and Public Safety, the private sector, meaning employers and businesses, the media, academia in terms of subject matter expertise from academic institutions that can be brought to bear during the disaster life cycle, communities. In the United States, for example, there are community emergency response teams, so community engagement is a critical piece. And last but not least, healthcare delivery systems ranging from pre-hospital care, such as EMS, to hospital-based care and treatment. So again, this slide, as depicted here, reflects the intersecting nature of this multifaceted system. Let's think about also some really burning questions that we must consider in disasters from an environmental health sciences, or EHS, angle. So importantly, when we think about disasters, we need to think of them in terms of environmental considerations. What agents, for example, were naturally or accidentally or even intentionally released into the environment? Where is the agent located in the environment, and where will it go? For example, if there is an explosion that contains radiation in the form of what's called a dirty bomb or radiological dispersal device, more formally, where is the plume going? That information is important to help public health officials guide the community when, whether, and where to evacuate and how to evacuate. Another question is who will be exposed to this event and what is the level of exposure? What will happen to those who are exposed? What are the acute and longer-term health effects? And what can we do to reduce exposure and treat victims? So all of these questions are critical and are directly relevant to the kinds of considerations that are part of the Pocket Map series. Let's talk about these WH questions, the what, where, etc., from my previous slide, in the context of the September 11, 2001 attacks on the World Trade Center. So when we think about this tragedy from an environmental health standpoint, we think about things like how much jet fuel combusted and the temperatures at which the jet fuel from the planes that were crashed into the World Trade Center emitted. What was the plume like? What did it contain? What happened in terms of materials that were released, including hazardous materials, when the World Trade Centers collapsed? So thousands of tons of particulate matter, including many things that are hazardous to health and safety. So these are the kinds of what questions that we need to include when we think about environmental health considerations in disasters. Very importantly, also, when we think about environmental health considerations, we need to think about exposure assessment. It's important to assess what materials people were exposed to, whether we're talking about those who were victims of the event or survivors of the event, and those who are responding to the event. So these kinds of exposure considerations include, in the case of the World Trade Center attacks from September 11, 2001, settled dust, airborne particulate matter, trace elements, dioxin, and airborne polycyclic aromatic hydrocarbons. So these are the kinds of exposure assessments that we need to do in public health through environmental health services to ensure the monitoring and safety of those who were exposed to these events and who are responding to them and are therefore also exposed to these events. Here are some where questions that relate to September 11, 2001 in New York City. Where was the plume? So we thankfully now have excellent satellite imaging systems and geographic information system technology at our disposal to allow us to monitor the dispersal of an explosive event, or in this case, the plume following the planes flying into the World Trade Center. So this image depicts the dispersal of this plume containing the kinds of materials that I alluded to a few moments ago over Lower Manhattan, Brooklyn, and miles beyond. In this case, this is a depiction of Lower Manhattan and the plume. There are some important who questions when we do environmental risk assessments in the acute aftermath and even longer term aftermath of disasters. So both for the response phase that I alluded to earlier and the recovery phase. Who was exposed? Well, in this case, on September 11, 2001, in the aftermath, everyone who was living or working in Lower Manhattan, Brooklyn, and miles beyond were exposed. Subgroups who were at greatest risk of exposure included, as listed here, firefighters, police, and paramedics, so first responders, construction workers and volunteers, workers who cleaned World Trade Center dust from the nearby buildings, women who were pregnant on September 11, 2001. There were 3,000 children who resided within 1 kilometer of the World Trade Center. And there were 5,500 children who attended school within 1 kilometer. It's also important to know when an event occurred. So this tragedy occurred on a school day right after 9 a.m. Eastern time in the US. So these are the kinds of considerations in terms of who was exposed and where were they when they were exposed. All of these are relevant to response considerations and monitoring for subsequent surveillance in the recovery phase, as I alluded to earlier. As I mentioned also, and I want to highlight here for emphasis, all disasters, no matter their scope, begin locally. And a key corollary for that is that preparedness, response, and recovery efforts begin locally. There's a term that is used and that's relevant here called the all hazards model. And what that means is various systems such as incident command system in the US and other standardized approaches that can be adapted for different types of events, whether they're intentionally caused, whether they're pandemics, whether they're hazardous material related or otherwise. The same systems, in this case, for example, the incident command system, are adaptable across hazards. And that's what we call the all hazards model. Now, all disasters are different, and even disaster categories have nuances of difference from one such event to another. But the point here is that we can avail ourselves of standardized models, such as incident command system response models, to tailor our response across different types of hazards. Again, that's what we mean by the all hazards model. There are some acronyms in disaster preparedness and response. One of them is CBRNE, and that stands for chemical, biological, radiological, nuclear, and explosive weapons. And interestingly, these weapons in many ways have more similarities than differences, as counterintuitive as that may sound. Much of the aspects that are common through lines among these various categories relate to psychosocial considerations. So terrorism is fundamentally a mental health assault on populations, as horrific and awful as the physical impacts are. From the standpoint of the perpetrator, the goal of such an attack is to elicit fear and literally terror on communities and larger regions. So having said that, the psychosocial aspects are all relevant as a through line that connects these various categories of types of events. Let's talk in a little more detail about these types of threats, and I'll specifically focus briefly here on chemical, biological, radiological, and nuclear. The reality here is that all of these events, whether they're biological, radiological, chemical, or nuclear, relate to the disaster life cycle that I had alluded to previously, and that I've depicted the phases right here on this slide just for convenience. So we want to prevent, release, or acquisition of hazardous materials for use in an attack. We want to do preparedness activities, planning for, training for, exercising, and evaluating before an event of any of these categories. We want to be rapidly responsive, and by we, I mean that's the public health preparedness system that I depicted earlier in the diagram. And we want to be ready for recovery. What I'm about to say may seem counterintuitive, but it's important to note. The recovery activities need to actually begin concurrently or close to concurrently with response activities. In other words, we need to begin planning for recovery even in the acute aftermath of an event. We don't want to wait till the end of the response phase and then begin thinking about recovery for the first time. That will create a disjunction within the disaster life cycle and can erode effective recovery. So that's an important take-home point. Let's think about who are involved. This is amplifying the previous slide of the public health preparedness system. And these kinds of actors include political leadership, Homeland Security, a web of federal, state, and local agencies, even international agencies, of course. Think about WHO and the declaration of COVID-19 pandemic. Emergency responders, intelligence of what's going on. We call that situational awareness. Law enforcement, the military, the civilian public health sector, healthcare providers, the media, and the general public, and many more that are not listed here, but are reflected in the public health emergency preparedness system from earlier. A critical question that we always need to ask in response to a public health emergency or disaster is who's in charge? And I had alluded to a few moments ago the incident command system. The incident command system, it's very much a hierarchical system. It has been in place since the 1970s in the United States. And it, in many ways, is a very military-like system with a command and control structure. So one of the challenges in public health agencies is we don't use in public health agencies command and control military-like organizational charts and related activities on a day-to-day basis. So adapting from a day-to-day public health operational mode to a disaster incident command related mode is a challenge for public health departments in a way that it may not be as much of a challenge for agencies that use incident command on a day-to-day basis, like law enforcement and fire services. Coordination is a critical piece within incident response and recovery, I might add, and communication can make or break a response to a public health emergency or disaster. So by communication, I'm referring to communication between and among response agencies and communication between response agencies and the general public. It's critical that we have harmonized risk messaging occurring. One of the lessons learned from COVID-19 has included challenges with what is referred to as an infodemic, which can include misinformation, which is another word for inaccurate information, and in some instances, disinformation, which is intentionally inaccurate information. So communication is one of the hardest things that we do in public health generally, and in a disaster, it's absolutely critical that communication occurs in a harmonized and effective, efficient manner. Thank you very much.